take place fourth Tuesday of each month from 12:15 to 1:15. I'm Ravitch. I'm the director of MCPAP. And today's topic is MCPAP Clinical Conversations, Resource Referral Services for MCPAP 2.0 Care Coordination Redefined. A housekeeping note, this will be recorded and it will be available on the MCPAP website at www.mcpap.org and be on the About Us section under News Events. My slides will also be available in that same place under Archive News and Webinars. So you can have the slides separately or you can listen to the whole webinar together. Our presenter questions at several points during the presentation, and there will be time at the end of the presentation for questions and discussion. If you have a question or a comment, please type it into the question box during the presentation, and we will either read it out or unmute your line to enable you to ask your question at the appropriate time. Your very brief survey following the webinar. We appreciate it if you could take a moment to complete that, as your feedback helps us improve our future presentations. I'm going to introduce today's distinguished presenters. We have Leah Grant, MSW, LICSW. Leah graduated from Boston University School of Social Work. She has worked with families in the mental health field since 1984 in a variety of settings. Community health, therapeutic care for abused and neglected children, and on-site therapy at a daycare and after-school program. Utilizes in play therapy and sand play therapy. Currently serves as a behavioral health clinician on the MCPAP Massachusetts General Hospital team. Paula Vanesian, RN, BSN, medical home coordinator at Main Street Pediatrics in Hopkinton. She went to Elizabeth School of Nursing and Emmanuel College. She worked in acute care hospital for 17 years. Hired staff nurse at Main Street Pediatrics in 2002. She accepted the position of medical home coordinator in 2009. And we also have Jessica McGovern, MD. Dr. McGovern attended Georgetown University of Medicine and completed her internships and residency program at Tufts Medical Center Floating Hospital for Children, where she acted as chief resident in pediatrics until 2005. She joined Milton Pediatrics in July of that year. Dr. McGovern is a member of the American Academy of Pediatrics and is certified by the American Board of Pediatrics. We that you'll find this panel illustrates of the various models we'll be talking about. We understand at MCPAP that some practices have care coordinators and some practices don't have access to care coordinators. So we're going to be talking about resource and referral and care coordination in context of both models. So over to Leah.
This is Leah, and I just like to give a little disclaimer at the beginning. I am not technologically savvy, so I'm just going to apologize now for any glitches that I have occur. I'm not sure what slide everybody is on.
First one.
Okay. So what I want to do is, and again, as Marcy said, please feel free to interrupt. I thought it would be helpful to do a little review, a very small review of what the services looked like for the first 12 years of MCPAP before we changed over this year. As you all know, you could speak with a child and adolescent psychiatrist on the phone, asking all sorts of questions and requesting a face-to-face consult. You do the same with a behavioral health clinician at your site, obviously not related to medication, but with more questions appropriate for them. And then what we used to call care coordination services, and that would be find sources or, more specifically therapy and psychiatry, whether you as the doctor or nurse practitioner wanted to give that to the family yourself or have us call the parents, we would provide that. And can I make the slide go by myself?
That's me. Just tell me when you want me to go to the next slide.
Okay, that was great. Sorry, Mary. All right, so again, we thought it would be helpful to talk about why this change. So we called these folks care coordinators for a very long time, but really what they were doing was resource and referral. You know, trying to find whatever it was that the family needed for mental health services. And we really thought what care coordination was. I thought it was helpful, you know, taking it from the American Academy of Pediatrics website, way more than what we were doing. What we were doing was finding the resources and letting the family or you folks know. And with this new medical home model, care coordination is, quote, the deliberate organization of patient care activities between two or more participants, including a patient involved in a patient's care, to facilitate the appropriate delivery of healthcare services. So it's above and beyond what we do. And so the definition that we've got now of resource and referral, what we're calling R&R, is identifying potential and appropriate treatment resources for the patient and giving the family or practice the contact info to connect and engage with treatment. So he was certainly driving this, and I think we all agreed as we were heading towards this new reconfiguration of MCPAP 2.0, we need to be really careful and specific with our language. And so that's why we decided to change it. Mary, next slide, please. So to continue with that, why we're changing, partner with the medical home invested in helping train whoever you folks have as care coordinators. Some practices have embedded care coordinators, or you know, it's a behavioral health clinician doing that work, and some don't. And so it's an assumption that that model is going to be the norm. So we're able to support our pediatric practices across the state with whatever it is need. So that's, but being real specific about coordination as something different than resource and referral. There was also a care coordination follow-up pilot, and we would send families resources and then try to follow up with them, and we had limited success. We also had a provider experience survey that showed frustration with this limited success. And what we found, whether it's the care coordinator, the old care coordinator, our resource and referral specialists, or even the behavioral health clinicians calling to do some of the resource and referral, if it's us calling, the parents don't answer. If it's the pediatric practice calling, the odds that they're going to answer are much greater. And so it just seemed to make more sense to have this be a function of the pediatric practice. Right? Thanks, Meg. So we thought it would be helpful to talk a bit about resource and referral and how this kind of coordinates, or not coordinates, but how this jives with care coordination, the values. So the first stage, behavioral health is fundamental to overall health and wellness. We want to always include the family, not just throwing them resources, but making sure that to the best of our ability, it's going to match them. Really, I mean, it's a tricky thing, and we've been doing this for a long time. And we try our best, and we know you try your best, and the family tries their best, and sometimes it's a big task. You know, there's gamut of you just need a therapist, there's just been a little adjustment disorder, versus this kid needs wraparound. So we really want to involve, we really want to have our knowledge transfer over to you and help the system, empowering the families, working pediatric practices, making sure that no matter whether it's a big or small mental health issue, the family gets what they need, because especially with kids, it's not just the patient. Next slide, please, Mary. So we're going to delineate it as two different kind of referral and resource services. The first is to the provider. So this is a doc or a nurse practitioner will call us and say, hey, we've got this type of patient who lives here with this type of insurance. And we would try to get back to you within 3 business days. Sometimes, as you all know, insurance and location can be an issue. Sometimes transportation, I mean, the list goes on. We will do our best to get you those. And that, we can deliver that via phone, via email, via faxing. Next slide. And outreach to families. This is for the more complex cases, so you would contact families taking in the times they've been in or out of treatment, what barriers there would be to access that treatment. A lot of these families can be involved with, they need help with school. It's just more than what we would consider an average sort of request for therapy. So the R&R specialist would call the family, get more information. Obviously, would have information from the pediatrician, would get more information from the family, then very hard to call and find out so they can go. And we have a form that will to the pediatrician so that it can get into the child's chart. So if there's some sort of communication problem, or say I had done the resources and I was out on vacation or a sick day, if the family tries to call or the doc tries to call, you're not just waiting for me to come back. It's actually been sent to you and it's in the patient's chart. This is the kind of thing now where if you want the R&R provider to call family, it would be a discussion between either the behavioral health clinician or the MCPAP psychiatrist, pediatrician, or pediatrics practitioner, because we make sure that this, because it's such an intense resource, that we're not stretching our limits with that. Please. All right, so here's kind of the nitty-gritty of it all, and this is where the hits the road for us. We try very, very hard to make sure that the resources we give the families or the docs are the best that we can find. So then we're having conversations with pediatricians, we're having conversations with the family. We find out what it is that is going to best suit this family. Also, we explain to the family this is a situation where you're going to be making the phone calls and have tips at the end to the parents, whoever, or the guardian, whoever is going to be making that phone call. Also, things about, the behavioral health system, it's going to be different than calling the pediatrician. And there'll be more details about that later. And where it says provide multiple treatment and or service provider options whenever possible, that is going to be dependent on insurance and where the family lives. Next slide, please. Thanks. The initial call with the family. Okay, as we all know, it kicks off with insurance. And this can be easy, difficult, a PO versus an HMO. That's definitely going to be part of the conversation. Transportation needs. Some families need to be on a public transportation line. Some families want to know if their 15-year-old can go by themselves. The answer to that is, of course, not for the first visit. And how far are they willing to travel? And sometimes, families say to us, oh, no, I don't mind. And we explain, you've got a 5-year-old who tantrums all the time. It probably is not in the 5-year-old's best interest to be in a car for 45 minutes going to a therapist. Language needs, certainly want to take that into account. Language, religion, culture. Some folks, for whatever reason, prefer male versus female, female versus male. Does it have to be after school? Is there a work problem? Not problem, but do the parents work? Can we be after school? Sometimes that means explaining to parents, if your child is involved in after-school activities every day of the week, something's going to have to give up because therapists aren't going to have a 9 o'clock appointment on a Sunday for a kid. And and the week. Previous treatment, sometimes kids are new to therapy, sometimes they're not. That's an important conversation. You know, I mean, I've had parents say to me, you know, the office was dirty and we didn't want our kids in there. So there's another good question to flesh out. Next slide, please, Mary. Another important point is the private practice versus a group practice versus a clinic practice. Some families, the request is we just want a psychiatrist, and a lot of times you can't just have a psychiatrist unless you're willing to pay out of pocket. So private practice versus a community mental health center, this is an outpatient practice at a hospital. We go through all those parameters. Some parents aren't sure if they want to have their kid take meds, even though the meds are recommended. We educate around, you know, if you start with therapy and it's a single practitioner, it's hard to find a therapist. It may be hard to find a psychiatrist who would be willing to do meds unless they're affiliated with a practice. A lot of psychiatrists don't really, for licensing reasons, don't really feel comfortable medicating kids that they don't know who the therapist is. So parents know about that. Shortage of child psychiatry and some special forms of therapy, if that's relevant. That's always a conversation. We best to find wait times. A lot of times clinics will say, we call to do the vetting. We know what the wait time is going to be because we need to take the intake information and then see who's available to match it. And so that's another conversation with the family. We try to do our best, but sometimes we hit these walls. The clinic that says, yes, we take fill in the blank insurance, but every provider at that clinic will take insurance. So if a family is online looking at a particular website and really likes the looks and the bio of a therapist, that therapist might not take their insurance. So we do our best to figure that stuff out. The more flexible the family can be, the more options they may have. And, you know, people are as flexible as they can be, so we include that in the conversation. Mary, next slide.
A good time for Paula and Jess to talk about how they experience this in their practices. We're going to
start. This is Jessica.
Good.
All right. So I am part of general pediatric practice where there's 13 doctors, and we do not have a medical home care coordinator. It's probably something on our list for the future, but we've been working on converting to Epic, and that keeps getting postponed. So one thing at a time. But I think for our practice, we do have trouble accessing mental health care for our patients. You know, we have our local referral list, which we try to match up with patients usually according to location and what the therapist, you know, age group that the therapist generally deals with. But I have to say that a lot of time access, tax or insurance really make us give a very long list of patients, and it puts a lot of onus on the families to try to set this up. And you know, I mostly, because we don't have a care coordinator, rely upon the family to call me if they're having trouble, because I often call back every person that I do make a community referral for therapy to. And the second part of that is just psychiatric care is, you know, almost impossible to access in a timely fashion for us. Sometimes it's hard to know who is going to be recommended to start on medicine and who is not, but certainly the more complex patients, I do try to triage towards the bigger groups have psychopharmacologists. But again, even if they're in that group, seeing a therapist there, the appointment for the psychopharmacologist is often months and months away. So that's a barrier that we find as well. It makes things a little bit more difficult and makes me call MCPAP often for medication advice. So, and most of us, you know, in our practice are willing to start, you know, a baseline SRI if it's the right patient, the diagnosis seems clear, we don't have any, red flags with family history or medical history. But if that, first medication that we're comfortable with trying doesn't work, we also often get stuck with where do we go from there. So that's answering the question, but that's sort of our on things. We do, because we're a partners affiliated practice, we have access to a case management program through Mass General, which provides us with a social worker that we can often access pretty easily. And with the more complex patients, she'll actually enter them into her database and do some follow-up with them. So that's been an incredible improvement for a lot of us last year and a half that we've had access to that program.
Great, thanks, Jessica.
You're welcome.
I'm wondering what it's like for Paula, who's actually a mental home care coordinator, and how that differs.
So, home care coordinator at Main Street Pediatrics, and we have 9 providers, 6 physicians, and 3 nurse practitioners. And my position as medical home care coordinator started out in 2009, and it wasn't as care coordination for behavioral health. When we started the term medical home care coordinator, it was identified more for our patients that had complex medical needs. And, following up with all their appointments and assisting them with things going on. As it kind of evolved over the past couple of years, where behavioral health has become a major issue with all these young children, my role has slightly changed. I mean, I'm still doing the complex children, but care coordination to assist parents with behavioral health has become an immense problem. For a while, I was doing a lot of the R&R and care coordination, and with assistance with MCPAP, I used the Worcester MCPAP for quite a while and had a good rapport with them. But as we've to change our models, that's okay. We had also hired a behavioral health person in our office, which is immensely. Our physicians do feel fairly comfortable prescribing, but will call MCPAP if there has been, if they've done a trial of a couple of SSRIs and just not working right for the child, call back and speak to MCPAP and speak to the psychiatry. Having the behavioral health person in the office has really helped our physician a lot. We're only doing short-term in the office. We do still need to do a lot of care coordination to have our families have to have long-term therapy, or if they need psychiatric care beyond our physicians. The only thing I was going to mention is we have, Marcy had asked me to mention it, was that we had a great couple meetings in our town and also in the town in Northborough and Southborough. And the school put together some behavioral health meetings, which was very beneficial. We got to meet other providers in the area. We got to meet psychologists, social workers, guidance counselors, everybody that's kind of in our area that works with children got together, and everybody exchanged info, and we've got a lot of great resources going that way. So it's kind of a good thing if you could hook up, if you could have anybody in your office hook up with, the schools within your towns and kind of get something like that going, and to really get behavioral health as top priority in the schools.
Yeah. Should we finish talking about what we think are best practices moving forward?
Sorry. I'll be pressing questions right now. So next slide, please. Thank you. So again, it's not just a quick call. Hey, there's 3 clinics, ready, go. We have tried that in the ancient past, and give families, even if they are pretty savvy to the system, it's still helpful to talk with them about, when you call, here you can expect respect. And don't just hang up and get frustrated. But when you do get frustrated, absolutely call us back or call your provider back, your kid's provider. There could wait time. What we try to do is when we call to vet these places, we try to find out the answers to these questions. Is there a specific intake coordinator? Is it the kind of clinic where you just call the extension of the therapist you're interested in? How much paperwork is there? Some places do a very long initial appointment, and ongoing appointments are like the 45 or 50-minute clinical hour. Guardian, I had mentioned earlier, can a 15-year-old go by him or herself? Some places want parents there all the time, depending on what they feel their liability is. So we hit on all these points when we're talking with parents and when we're talking with the practices to find out the answers to these questions. Another big one is we recommend that bring the child at least 3 times, and just going once and hearing negative feedback, I don't want to go. We really ask them to give it 3 chances. And sometimes it's just a bad match no matter what. And I've said to parents on the phone, I can tell you where I think a great place would be. You're going to know your kid better, and you're going to know when you call to make the appointment that this is going to be, the shot, and you definitely need to go for 3 times, or, oh, it's going to be the best match ever. So it's really, again, having these conversations with parents about how to get their kid to the right place. Next slide, please, Mary. There's so much out there, and I say that because when we first started doing this, the internet was available, but there were not a lot of places online. We rely on one of our favorite resources, the Interface Referral Service at William James College, and we have a collaboration with them where we can access their database, but this is also a service that families who are in towns that the database serves can call, and people at William James College Face will help them with the referral. That would be a website that we would send people to. There's Psychology Today. All the insurance companies now have websites that are okay, I want to say. There's Therapy Tribe. There's Help Pro. We have, in a pinch, Googled, therapy, Mansfield, little kids, and seen what pops up. So it seems like there are options out there that there did not used to be a while ago. And I think what Paula was talking about, with the schools, but it can community-based behavioral health providers in your community, and a friendly voice on the phone goes a long way, as I'm sure you all know. We often get the question, and I know Jessica can relate to this, oh, you guys are at MGH, can we get in? We don't have any magic pull. But we do recommend, if you can develop a relationship with somebody at an office, that's just going to be a bonus for your patients. Slide, please. So the desired outcome of care coordination. We want referrals that are going to work, that are going to stick, that is going to mean for families trying to find that right match. So we want these children and adolescents to get the services and then continue with the recommended treatment. A big question a while ago was, there were a bunch of practices, and it seemed like everybody was pregnant, and so we would call and we would say, do you have openings for this type of therapy with this age kid? And is the person going to go out on maternity leave? So we really wanted to make sure that we weren't giving kids recommendations when we knew that the therapist was going to be leaving. And then you got to follow up with the family, and how are things going with therapy, and is it a good match? Have they tried 3 times? Well, what did the psychiatrist say? How long is it a wait? Those kind of things. Next slide, please, Mary. Then one of our Resource and Referral specialists came up with these helpful tips for families. And it's a list that we now include when we send resources to families and also the pediatricians. And it's a little bit of what it's more of what I touched on a little bit ago about how therapists will often do their own phone calls and return their own messages. It's okay to leave your name and number and how to do that. If you call a larger practice instead of an individual provider, the same principles apply. Follow the automated prompts, that kind of thing. Next slide, please, Mary. Giving them the advice that, allow 2 days for the person to get back to you or the intake coordinator to get back to you. There are times of year that are just jam-packed for these places, and if it's a big practice that only takes insurance, and your insurance is a tricky one, you need to give people a chance to respond. After 2 days, leave another message, and then after that, let PCP know. Again, what I had said before about continue for 2 to 3 visits before making a final decision. Also, it's important to let the therapist know why it's not working, and then they can address that. Some things are full, some things aren't. Are we at the end now, Mary? I don't think so. There we go. That's it. Sorry. So if they do something you don't like or it's not a good match, talk about it with the therapist, and hopefully they'll be able to make it right for you. And then when you bump into anything that is not going okay based on the recommendations, let the pediatrician know what the trouble is. Either the kid didn't like it, or they said they'd be open and they weren't, whatever your issues are. And I think that is the end of the slideshow. So, Marcy, Mary, at this point, do we open for questions? Sorry.
Yes, we're going to open it up for questions. We do have a couple. I want to just go back and emphasize something that you were talking about toward the beginning, Leah, which is why. Oh, it's fine. Because I think this bears repeating, and the reason, or one of the reasons, probably the main reasons that we made the decision to pull back on the outreach to family and really give the primary care office the responsibility for working with the family and specifically for following up with the family is that you have a relationship with the family. You're more likely going to be able to motivate them to go and or follow through with treatment and be in a position to follow up. Because even if you can't reach them, like we can't reach them because their phone number changed or all those reasons, they'll eventually come back into your office to see you for something. And then you can follow up with them about what happened. We're never going to have another touch point with these folks. We won't have that ability. So, looks like Paula wants to say something about that.
Yeah, I just wanted to say you could ask the families to sign releases when they go to their behavioral person, because a lot of times we don't get notes, and this is part of the care coordination, is to do the follow-up part. If families aren't signing releases for us to get any information back from the therapist or the psychiatrist, we're kind of stuck in limbo land. So just be something, if you could just, incorporate to your families to say, just sign a release so that Dr. So-and-so can get notes back and to see what's going on, especially if there's medication management.
That's a really good point, because particularly now with the medical home model, the PCP is managing the child's care, the total care. So they should be able to get that information. Okay, so let's get to the questions. Here's the first one. We are developing care teams at our site. Can our NP or nurse call and ask for a specific type of list, particularly if it is a more general list?
Well, sorry about that. Who's asking that? I'm
Michelle Dalal.
Okay. So they're developing care teams. So can she be unmuted so that I don't really know how to do the questions, Marcy. Sorry, it's my first webinar. So
Michelle, you've been unmuted.
Thank you so much. Michelle, hi, it's Leah. So when you say you're developing care teams, like coordination?
No, I mean, we have care team models where we work closely with our nurse who's situated next to us and our medical assistant. So my question is, if we are trying to get a list of therapists, let's say Spanish-speaking therapists in Milton, Massachusetts, which is where I work, are we going to have them call you and sort of get a list of that so we can put that in our database? Because that's one thing we're lacking.
Isn't that a good question? I don't know. I mean, you can absolutely call us, and I think that ties into the question below that. Can a social worker call if they're having difficulty with making a specific referral? Absolutely. If you have been working and working and working, sometimes the answer is you've done everything you can do. So definitely call. With lists, we were best to help you facilitate a list. I don't know that we have lists because when we do the resource and referral, not every case is the same, and so we find, even if it's still like a 7-year-old with Blue Cross Blue Shield, we still, because things change so quickly, we would still call all the same places again. So does that make sense? So I would have your practitioner call, and we would talk about what it is you're looking for, and if we don't have that list, we could help you find a way to get it.
Okay, great. Thank you.
Okay.
Next question is Deb, but you have a question.
Sure.
Hi, muted.
Hey, okay. Yes, I was just, in our area, we are having, I'm out in Western Mass, like as far as you can go on the Mass Pike, but we are having an increasing issue with autism diagnoses because of the issue of the schools are now having to provide certain kinds of like ABA type behavior or modification type things. They require certain people, doing certain tests for diagnosis. So I don't know if maybe you guys have had some experience around that kind of issue that you could speak to.
So I just want to make sure I understand your question, Deb. You are as far west as we can go and still be in Massachusetts. And there are kids in your community who need an autism diagnosis and ABA because the schools are requiring the autism diagnosis before they'll provide the ABA?
Right, exactly.
Okay, and so you are wondering if we know providers out west who can facilitate the patients getting an autism diagnosis.
But also I think that's becoming more of a general, if you want to speak generally to how you guys are managing this, maybe having problems out there, but I think that, general diagnosis has to come from a developmental pediatrician, and it's very hard to get with them. So, yeah.
I actually answer that. This is Marcy. Yes, we are having problems. That is a problem that exists across the state. There are very few developmental pediatricians in the same vein that there are very few child psychiatrists. We were actually just talking about this morning at our team meeting. In other states, they've done away with that requirement, or in some states, that you have to have the diagnosis before you're able to get, whether it's ABA or early intervention services. And that makes accessing services certainly more easy. But this is a topic that we're going to be discussing and looking into more. But yeah, we are struggling across the state to be able to provide resources specifically for on the spectrum.
Oh, that's helpful. I guess I could. So this is something I could call an R person, and they can help me locally, as you can at this point.
Yeah.
Okay.
I want to remind people of that I always say when I go out and talk to groups is that here at MCPAP, we don't have a magic wand. We don't create resources that aren't already there. and we don't have some magic way of getting people into the resources that are there. It's really going back to what Leah was talking about, what Paula was talking about. It's about the relationship. To the extent that you can develop relationships in your communities with local behavioral health providers, you're going to have an easier time of getting your kids into treatment. Only magic is developing those relationships and, you know, hopefully sometimes being able to get moved up on waiting lists or, you know, an emergency or urgent situation, you know, to get a kid in sooner. But in general, there's no magic to it. The relationship is the magic. We have a question from Margaret Hanna. Margaret?
Hi, guys. I changed my mind, so I'm good.
Okay. Thanks, Margaret. Paula's got her hand up.
Oh,
Okay.
before.
Thanks.
One thing I want to mention in terms of some of these issues that we struggle with across the state, or even in specific areas of the state, MCPAP staff participate actively in a variety of different venues. We can bring these issues to the Children's Mental Health Task Force or to the Department of Health through our regular meetings with them to be able to raise issues in a statewide forum where there's advocacy that can be done.
I always say, yeah, to get information back to MCPAP Central, because that's where the activism happens.
We try.
You do better than that.
Any questions? Any examples they want to throw out that they're having trouble with?
Question down here. Can we send an email to a centralized email to ask for a specific type of referral, or do we still have to call so we can talk it through? Okay. Or case discussions. Thank you all for joining us today. I hope this was valuable. Want to let you know that MCPAP is available to come to your practice, delve in a little more detail around resource and referral, and help you develop your own care coordination practice. So again, practice, you know, consultation on site at your practice is available for this, or through webinar or video conferencing. So you can let your team know, or you can let us know centrally if you're interested in that. For questions from this webinar. We hope that you'll take a moment to do the post-webinar survey. Again, that really does help us improve moving forward. And our next clinical conversation will be the 4th Tuesday of April, and that topic is going to be about developmental screening. We're going to be talking about the new screening tool called the SWIC, which stands for Social Being of Young Children, and we'll have its developer, Dr. Ellen Perrin, with us to speak about that. This webinar will be available again on our website for your colleagues that missed it, or if you want to listen to it again. Thanks again for joining us, and we look forward to seeing you next month.
Thank you.
Bye.